Hello everyone. So this is my second case of interesting cases. So this patient is a 45-year-old vendor. He presented with difficulty in walking, with progressive difficulty to get up from squat, numbness of limbs of 1 week duration. And when I saw him, he was virtually crawling on the ground. He's a vendor in the market without any significant comorbid illnesses, but he used to take alcohol and various substances like ganja and other things because it's a job and profession in the market and things like that. Examination showed that he was fully conscious oriented, afebrile, with a full Glasgow coma scale. He had clubbing, he had tobacco stains in the fingers, hoarseness with bilateral pitting pedalema. Cranial nerves and upper limbs were normal. But the lower limb showed bilateral hypotonic limbs with muscle power of 2/5. That means fairly markedly weak. Hip flexion extension were nearly 2 minus and 2 respectively. Knee extension were also weak bilaterally, and knee flexion fairly good. And the dorsiflexion and plantar flexion of the feet were extra normal, and he had a wasted quadriceps on either sides. Upper limb deep tendon reflex were preserved, but lower limb ankle jack and knee jack were absent. Plantars were flexor. No muscle tenderness or neck stiffness. SLR straight leg raising test was negative on either side. Faber was negative. He had impaired position sensation in the hands and feet with joint position sense and vibrations intact. There is no incoordination or dysarthria. Investigations were largely normal except that his ESR was high 110, and ANA was weakly positive, and all other tests like sugar, calcium, electrophoresis, HIV, VDRL, HCV, RFT, LFT, everything, B12, everything was normal. Nerve condition showed a sensory motor neuropathy involving both upper and lower limb, predominantly axonal type. You can see that. And this is X-ray chest. X-ray chest showed that there are some patches in the right upper zone. So CSF study done which was normal, no albinocytical dissociation, malignant cells were negative, AFB cultures, fungal smear were negative. And the clinical diagnosis was bilateral lumbosacral plexitis and NCS evidence of peripheral neuropathy. So we were thinking whether this could be paraneoplastic, that means due to malignancy. So underwent a bronchoscopic study which showed that normal flora. Ball study for AFP was negative, AFB culture was negative, Mando was also negative. But BAL Mycobacterium tuberculosis PCR was positive, and we did a CT thorax. You can see that there is a lesion, there is a patch in the right upper zone. And this is the reformator view. There is a cavitatory lesion in the right upper zone as well as a few patch on the left side as well. The dorsal MR spine, dorsal spine were normal. We started on ATT, anti-tuberculosis therapy, methyl prednisolone, physiotherapy, high protein diet, injection thiamine, and a psychiatric evaluation for his substance abuse. No improvement at all, even after 5 days and physiotherapy and methyl prednisolone. We expected some improvement. So then we thought of, because we were thinking could be paraneoplastic. So plasmapheresis was done 5 cycles and he fully improved. And we did a PET scan because with the possibility of a paraneoplastic pathology, you can see there is an avid uptake in the lung fields, especially on the right side. You can see there is a hypermetabolic area. Even on the left side there are, and some areas in the lymph node as well. You can see all those things. You can see the bright spot on the right side as well as few lesions on the left side as well. So PETs showed abnormal uptake of glucose and hypermetabolic activity in the hilar nodes as well as bilateral lung parenchyma more on the right side. And the final diagnosis was bilateral lumbosacral plexitis and mononeuritis multiplex, probably due to pulmonary tuberculosis, because The PET scan showed evidence more in suggestive of a infective pathology. Of course, the malignancy can also behave the same way, but this picture was highly suggestive of a metabolic or infective pathology. So the PET scan was suggestive of a infective pathology, and this showed hypermetabolic activity with increased glucose uptake. But there is no speculation, there is no other features of a malignancy in this case, and the AFP was positive. And what is lumbosacral plexitis? An idiopathic disorder characterized by acute onset of lower extremity pain followed by wasting and weakness and variable sensory loss. Multiple nerve roots or nerves can be affected, can be a sacral plexitis, lumbosacral plexitis, or a lumbar plexitis, usually occurring in diabetes, post-viral, post-vaccinal, post-traumatic, or paraneoplastic, many or familial, many things are possible. So usually it's painful, asymmetrical, asynchronous sensory motor peripheral neuropathy. Like a mononeuritis, is a non-contiguous involvement of multiple motor nerves, either in the upper limb, lower limb, face, or many areas. So this can be something like a plexitis and a neuropathy, something akin to a mononeuritis multiplex. So the various complications of tuberculosis, any part of the body can be affected in tuberculosis, like it can affect the skin, it can affect the lung, heart, brain, kidney, the joints, the genitourinary system, the reproductive system, the brain, spinal cord, the nerves, every organ system except maybe the nail and the hair, everything is affected. In the brain itself, it can cause hydrocephalus, meningitis, stroke due to vasculitis, venous thrombosis, cranial nerve palsies, seizures, tuberculoma, tuberculous abscess, end-plaque tuberculomas, then hypertrophic meningitis, diabetes insipidus due to hypothalamic lesion, seizures, and myelopathy, myeloradiculopathy, arachnoiditis, craniospinal arachnoiditis, Eel syndrome, SIADH, hyponatremia, even EELS as well as systemic inflammatory response syndrome. So many things as possible. So the TB may be related to the basic pathology, what caused the TB, like some immunosuppression, and the problem related to the tuberculosis. Thirdly, the complications of tuberculosis. Fourthly, the problem related to the drugs. Various drugs can cause hyperuricemia, rashes, neuropathy, psychosis, hepatitis, other various Steven-Johnson syndrome, many things are there, or eye toxicity, ataxia. So far there is no reported case of mononeuritis multiplex or lumbosacral plexitis in association with Mycobacterium tuberculosis. That's the reason why I want to present this case, because of the extreme rarity of the cases, because he presents with the plexitis, with the gross difficulty in walking the normal upper limb, though the NCS was suggestive of a sensory motor neuropathy with different motor nerves getting affected. The clinical symptomatology was confined in the lower limb in the distribution of a plexus, and with a lesion in the chest. Initially we thought this could be malignancy, later on turned out to be tuberculosis itself. And he responded to ATT as well as a 5 cycles of a plasma exchange. He didn't improve with the methylprednisolone. So okay, thank you very much.